Welcome to the VetRay Podcast, brought to you by Cetical, the world leader in veterinary-specific X-ray technology. Visit vetray.com to find a solution for you.
Today on the podcast, we have the pleasure of talking with Dr. Brian Poteet, a boarded veterinary radiologist, about teleradiology. Dr. Poteet, in addition to being the founder and president of VitalRads, a Houston, Texas-based teleradiology company, he is an associate professor at Texas A&M, accomplished lecturer and author. Please visit our website for an overview of his extensive educational background and many accomplishments.
One of the things I wanted to do is thank you, Dr. Poteet, for taking time out of your busy schedule and here between sessions at ACVR. I know at ACVR you're really packed and you've got activities like crazy. So I appreciate the time that we have with you to try and learn a little bit about telemedicine, how it benefits the practitioner and the client.
No problem, Emery. That's my pleasure.
Great. One of the things I guess I had a question on is, why does a general practitioner use telemedicine? I mean, is it just when they have, I don't know what the diagnosis really is, maybe there's two differentials I'm looking at? I guess explain a little bit more about how telemedicine benefits them.
Well, I think the majority of vets use it for just what you said. I think the majority of vets see cases from time to time that they have questions about that are perplexing to them, and they're on the fence of trying to make a diagnosis in their mind of what to do. You know, good examples of that are dogs that might be obstructed. Do they need to go to surgery? Do they not need to go to surgery? We need to make a decision right now. And so those cases, I think it's very helpful for them to send them out and get a timely answer back. Doesn't help anybody if you get the answer back and it's a day later or 12 hours later, because then the decision has probably usually already been made. So in those cases, I think it's very helpful if they get a timely report back. It comes back in 30 minutes or an hour, and then they can use that information to make a decision on what do I need to do with that dog right now, that patient right now. And so I think most of the veterinarians, they send cases from time to time, and these are more difficult cases that the diagnosis isn't apparent when they first look at the films. And then we get another group of veterinarians that kind of follow the human model. And in the human model, which AHA now recommends, is that they send every case they have out. And so every time they shoot an X-ray, and in reality it comes out to be 90% of them, because if it's the dog dies right afterwards, or it's an obvious broken leg or something like that, then maybe there's not a need. But those veterinarians that choose to send basically 90% of every case out, that becomes a standard of their practice. It's the standard that AHA wants everybody to do and recommends, and it's also the standard in human medicine. In human medicine, when anybody gets an X-ray, the general practitioner, the internist, may read it themselves first, but it always goes to a radiologist, and that's for a reason. And the radiologist is going to see things in that film that maybe the general practitioner didn't see. Maybe there's a nodule on the edge of the film, of the belly films on the dog, that may be obstructed. But if you see a nodule in the lungs and you shoot X-rays of the lungs, then maybe that presence of cancer in the lungs may change the owner's decision-making process of, do we really want to spend the money to cut this dog right now? So things like that maybe are on the edge of the film, or questionable findings that the radiologist is trained to see, because that's all we do, then I think those veterinarians that send out every film, they quickly realize the benefit of sending out those films.
Perfect example. I was talking to another radiologist here, and he was talking about the paradigm of a general practitioner who usually takes X-rays to finalize their diagnosis. And like exactly what you're saying is sometimes they're missing a lot of the other things that are in that image because they're looking for confirmation.
Right. And, a good example that I've talked to veterinarians and used this in the past is, when I give talks, I'll ask the kind of a poll in the audience. I'll say, well, everybody in here got some radiology training. Right, we did. And then I'll say, well, how many in here have diagnosed bowel wall thickening on a plain X-ray? and half the hands go up. I've diagnosed that, and they're happy that proud that they do it. Until I tell them that, did you know it's impossible to do that? You cannot diagnose bowel wall thickening on a plain film because the fluid that's in most bowel loops silhouettes or blends in with the bowel wall, and it may look thickened, but in most cases it's not thickened. So there's no way to do that, and then suddenly their hands come back down.
Do you find it hard for a general practitioner to try and incorporate the added costs of telemedicine? And again, I guess we should back up a little bit too and say, are the costs a benefit for general practitioners to maybe send more images out?
Yeah, I think that's a good question. It has kind of come full circle over time, and I think most of the time early on they would tack on an extra fee, an itemized extra fee for radiology interpretation, and they would cover the fee that the radiologist would charge their practice and maybe add $5 or $10 to make a little bit of profit on it and pay for the technician's time to enter into the request and send to us. But I think that's kind of gone by the wayside. People tend to look at the itemized bill and say, I don't want to pay this, or and so I think the way most practitioners are doing it right now is they just incorporate that $50 or $60 fee, whatever it is, into the price of the x-rays. And so suddenly now, instead of charging $120 for 2 views of a chest, you're charging $180 for 2 views of the chest, but it's included. And so that way, especially for those practitioners that choose to send every film out to be read, that way when they go to the client, there's no question about it. The client doesn't, it's kind of nice going in and saying, we're going to send these out to a veterinarian, to the radiologist to be read, but you don't have to pay any extra. It's already included in the cost. Okay, and for a lot of those clients that my practice does is we that choose to send in every case, is we send them. It looks like a diploma type thing that they can put in a frame and put it out in their waiting room, and it says something to the effect that in order for ABC Animal Hospital to provide the highest quality care to our patients, every radiograph is sent out to be read by a board-certified radiologist.
That's tremendous.
And that is in the waiting room. They put it on the wall, and so when the people are sitting there with their dog waiting to be seen, they see that and they're impressed with that, and then they don't have a problem with that little bit of an extra fee for the radiographs.
I guess that was going to go to a question I had about second opinion. The client brings the animal in, and they have a few x-rays, and they said, well, maybe this is what's wrong. It's going to cost X, and before they want to go to surgery or something, maybe they seek a second opinion. But if they have the films overread, that kind of is a second opinion and a confirmation that that's the course.
That's exactly right. And I can't tell you, from working in a clinical practice, in a clinical setting, providing radiology services in a referral-only hospital, how many times that animals came over to see us to have another procedure done, whether it be ultrasound or endoscopy or even go to surgery. And if the if the veterinarian would have sent those films out to be read by a radiologist, they wouldn't have never had to send the film to be referred. So the animal would have never been referred to begin with. So it saves money. It keeps money in your practice because some of those cases you don't need to send out. Yeah. And it also saves embarrassment for that veterinarian that, when they get the phone call back from the referring vet and say, if you would have read the films better, then, maybe you didn't even need to send it over here.
Now, one other question I had, with everybody going digital, we talked about a 2-view chest, lateral and VD.
Right.
Do you find that a lot of veterinarians, and as a radiologist, is it helpful for you for them to take additional films, even though it's not going to go back to a charge to the client? More information, the better the diagnosis.
Yes and no. We still are not a proponent of whole dogograms or whole catograms, and so, it gets back to general medicine. We want to encourage everybody to do a complete physical exam, try to localize the lesion to a particular area. If it's a dog that's lame and you localize pain to the elbow, it's better to shoot films centered over the elbow joint and get good quality films than shoot a whole dogogram and you got that's centered over the liver, because the films aren't going to be as good in the region of interest. And so, we want to encourage everybody to do a good physical exam, do a good orthopedic exam, and try to localize where the problem to a particular region and shoot x-rays of that region. Now, I think the standard of care nowadays, it used to be 2 views chest because of digital, and the films are quicker and they're so much higher quality. I think, things do change over time. So I think now instead of the 2-view chest standard, it's a 3-view chest standard. So we're getting both lateral views and a VD view. And kind of the same way with the abdomen. I think that's the standard now. It's just quicker, easier to do. You get better films. And it avoids us as the radiologist going back to those people and saying, why don't you get the other lateral view now? Because, that way you've already got it.
I was going to ask the question. So it's really good to get a left side down. I mean, everybody seems to do a right side down.
Yeah.
Good to do a left side down.
Right lateral is kind of the standard, I think, but it's not a right or wrong thing. There's some clinics that just do left laterals and some do right laterals. But I think, again, the trend is just do all 3.
I know a lot of the digital systems now, if you do a left lateral, so you do, let's say, feet towards the wall, you still want to view it in the same direction, same orientation as you do a right side.
Yeah, that's called hanging protocol. Okay. And so the radiologists are trained, and I'm a big advocate of this. Our accuracy is going to be higher if we orient the film on the monitor with the head and facing the same way every time. And so we always, no matter if it's a right lateral or a left lateral view of the chest or the skull or a stifle joint, we always want cranial to the left on the screen. So the cranial part of the dog should always be oriented to the left, no matter if it's a right lateral or a left lateral view.
So if they are taking the image, should they keep cranial to the left all the time, right and left? Or
no, it doesn't really matter. It doesn't matter because electronically you can flip it.
Okay.
Now, what we try to tell people to do, it saves us time as radiologists. Instead of us having to get films that are upside down and rotated the wrong way, we try to train the general practitioners to go ahead and flip them on your end, resave them on your end, all oriented correctly the same way, because it will also increase your ability to see things on those films because everything's oriented the same way every time you look at it. And also it saves us time because by the time they get to us, we don't have to spend time flipping films around.
Okay. Are there any other hints like that are helpful for a general practitioner, the veterinary tech taking images on positioning or collimating?
Yeah, there's, positioning is critical. And so, you want to make every lateral view, every VD view straight. And then there's some tips and tricks that you can do for a particular joint. Again, whether it's an elbow joint or a shoulder joint or whatever, you want to try to localize that pain to a particular joint, not just to a limb. And not just, the owner says, I see this all the time where the history, they'll come in and I get the history of the owner says he's limping on one of the front limbs, but they don't know which. And in my mind, that tells me they have not even put a hand on this dog and done an orthopedic or a physical exam because hopefully they can tell which limb if they actually tried to. And so we want to shoot not just the whole limb, not just both front limbs, but a particular region. And we want to make sure the films are properly exposed and they're straight.
Okay. Getting back to the number of images again, do you like to get sent just the minimum number of images, or again, would you like maybe a couple extra just for verification?
No, I think the minimum number of images over the region of interest, I think, is what we would want to have. If you have a dog that's coughing, and that's his primary complaint, there's really no reason to shoot abdominal films. If we have a dog that's vomiting, we want to make sure and get the whole abdomen. Some of these dogs are so big that even on a 14 by 17 flat panel, we can't get the whole dog abdomen in the same film at the same time. And so we don't, in a dog that's vomiting, for example, we don't want to get the mid-abdomen but not be able to see the stomach. And so sometimes we have to get 2 laterals, a cranial lateral of the abdomen and a caudal lateral of the abdomen, and same with the VD views to get the entire abdomen in the region of interest in the film.
That's good. I've heard, too, like when they do a METS check, a lot of times they won't send all the films to the radiologist because maybe positioning wasn't quite right or maybe it was a little blurred. And I've heard some radiologists say, send me everything. I may see something in one view that I didn't in
well, there's a trade-off there. I think as long as you get the entire thorax, in that particular case doing a MET check, I think as long as you get the entire thorax and you see all the way from the thoracic inlet all the way down to the diaphragm and the tips of the lungs, and you get both lateral views and a VD view and the entire thorax is in there and it's not blurry, then I think that will suffice.
We're good.
I think we're good there. Yeah.
Any other ideas or thoughts?
film quality, film quality, film quality. So, when you're going to buy a DR system, I would buy a flat panel detector, and I would make sure it's a good quality flat panel detector. There's a lot of bad ones out there that are sold. So I would make sure that it's a very good quality flat panel detector. And then, fortunately, the good quality flat panel detectors will take away a lot of the exposure problems that we used to see with film screen. So you're kind of eliminate that half of the problematic areas of getting a good quality x-ray. The other half is dependent on you and your technicians to be able to position the dog correctly. If you're going to shoot an elbow, again, you want to isolate that elbow out by itself. You don't want to put it in the middle of the chest. Things like that. So again, film quality is everything.
Do you kind of advocate sedation and tying the animal down, or doing
it depends on the animal, but I think the more we can sedate animals medically and safely do that, I think it does a couple of things for us. One is it makes the film quality usually better, and two, it helps with radiation exposure for radiation safety for your technicians, because usually we can get the films quicker and with less exposures if the animal's not fighting. So I think the sedation does help in a lot of ways.
I think we've pretty much covered everything, unless there's something you think.
No, Emery's a good guy, so I would buy everything from Emery.
Thank you again, Dr. Poteet.